Good morning, everyone. We're going to go ahead and get started. It's 10:31, and if anyone comes in, that's fine. They can find a seat. My name is Brittany Darling. Can everyone hear me okay? Great. I work with Emily Hicks Law, and thank you for joining us today for Continuum of Care. We're super excited to answer all of your questions, probably questions you didn't even know you had. So we're going to try and answer lots of questions today. Each speaker will speak for about 12 minutes, and then we'll pass it on to the next, and then we'll answer some questions after that, and then we'll go on to lunch after that, and hopefully you guys will have a chance to mingle with our speakers during lunch and answer some more questions, ask more questions that you have that came up during the speakers. I'm going to introduce all of them, and then I'm going to turn it over to Emily. So Emily is a proud Jacksonville. She's been here for about 20 years. Her legal experience began with tort litigation, and she moved from there into real estate law, estate planning. Her passion is to help families and small business owners protect their assets and their life's work. And then we have Chris Adams. He is with A Place at Home. Chris has been in the senior living industry for over 30 years. Both his mom and dad were both in healthcare at the same hospital, so he found himself naturally volunteering, developed a passion for the industry.
Forced about it.
He was voluntold to be there, right? Chris chose in-home healthcare to improve the quality of life for the elderly in his community. Next, we have Michael Saffy with SilverLink Consulting. He was lucky enough to know all of his grandparents and two of his great-grandparents, so he knows the value of taking care of the previous generation. He specializes in educating families on how services fit together to provide a network of care centered around your loved one. And finishing us off today is Charlene, and she is with Community Hospice. She's been there since 2000 in their healthcare relations department. Now she's in the community relations department and misspelling all kinds of myths and misinformation about hospice care. So we will turn it to Emily first, and then we'll get going. Thank you, Brittany.
Is this too loud? This feels really loud. Well, thank you so much, Brittany. That was a great introduction for all of us. We're very excited to be here, like she said, because we feel like there is so much misinformation out there, but really also a lack of information as one ages and goes through the process of what you may need as far as medical and healthcare related, but also on the legal side, and just navigating the system is really, really daunting. I mean, if anyone's even tried to sign up for healthcare insurance and even understand what Medicare even offers, I mean, we're bombarded with commercials all the time and all of these confusing things, and we really don't know, what to believe and what not to believe. So today I want to start by talking about just the basics of what you're going to need legally as far as getting a plan in place, because I know everybody's heard, oh, I need to do my estate plan. Well, what does that really mean? Who's heard of a will? Everyone knows what a will is, right? I mean, we all need a will. But what I want to really, talk about first is, what that will can do for you, but what also it does not do, because it's not a complete plan if you just have a will in place. And a lot of times, when families come to me, I like to think of it in terms of, where they are as far as this stage of life, because your plan is going to look very different if you are a young couple, a couple having children. Maybe you're what we like to call in your peak earning years, 40s and 50s, that's kind of a different, looking plan as well. Your kids are grown up. And then as you approach retirement and beyond, that plan may include thinking about, more long-term care and stuff like that planning, because that's really the part, and we'll get into it kind of at the end, my discussion here, but that's really the part where I need to dispel a lot of, myths and questions for people, because that's a really complicated system, and where people have a lot of misconceptions about Medicare versus Medicaid and things like that. So just to get started, what does a complete estate plan look like for most people? Do people here have a will in place? A lot of people have a will? Awesome. Okay. You guys better. Everyone's heard of a living trust or revocable trust. A lot of you may have those in place as well. And I just want to explain to you what that is. So when someone dies, I was watching this show last night, and the person, it was a murder thing. And the person, of course, dies. And it's this big production about the reading of the will, right? And the way the movies portray it is like everyone gathers and they read the will, and they just throw the car keys. Oh, Tommy gets the car, and Susie gets the house. And anyone who has a loved one that has passed away knows that is absolutely not what happens. People ask me, have you ever done a reading of the will? I'm like, no, I just, and that's not really, that's a movie thing. But anyway, what does happen is the court system called probate. So I want you to understand the consequences of just having a will. It's fine. It's great to at least have that in place, but do understand that is just a set of instructions that's going to be put through the probate system, so that a judge can then retitle all of your assets to whom you want them to go to. Hopefully, if the will is authenticated and everything is great, and the personal representative can then distribute your assets. So the way I like to look at it is there's two types of planning when you come for an estate plan. There's the planning that you do for after your death, okay? That's going to be really focused on asset distribution. And there's two ways to do that. You can do that through just having a will, or you can have some other things in place like a living trust or a revocable trust. And revocable just means that you can make any changes you want. You can obviously revoke it if you want. It's not set in stone until after passing. So a lot of times with a married couple, you would do a joint living trust, a joint revocable trust, because a lot of your assets are going to be owned together as a married couple. And what that does is that is a vehicle, okay? So I try to explain to people, because a trust sounds very fancy, right? It sounds like, I'm the Trump family. I don't, have all of this big estate or anything like that, is what I hear people often say. Like, I don't have, I don't need that. But really what it is it's a way it's an extension of yourself. It's not a separate tax entity like an LLC or something like that. It's an extension of yourself. You're making an agreement, a trust agreement, saying that I agree to transfer property to myself, from myself, to myself as trustee of my trust, okay? That's the simplest way to say it. And what that does is that then enables you to avoid the probate process, because that title in and of itself and that trust agreement, once you pass, we're going to have successor trustees. And the wonderful thing about that is they can automatically step in and manage your trust assets immediately. So there's no formal court process that has to take place. The retitling has been done ahead of time. It's a little more homework, up front, but the retitling part is really how I would, urge you to think about it, because the problem with distributing assets is always the title, right? Once you pass on, you're not signing any deeds anymore. You're not able to transfer any title. So there's no legal way to do it except through that formal process. So this is a way that we do it ahead of time. And another thing I want you to just, always remember is the beneficiary designations that you have on certain assets, like your retirement accounts and things like that. We always want to have those up to date, make sure they're going to the right people, because as life happens, sometimes there are remarriages, sometimes there are girlfriends or boyfriends that come into play, as we age. And, we have seen some ex-girlfriends accidentally inherit the IRA because the beneficiary designation wasn't up to date, and there is zero we can do about that, no matter what your will says. Okay, your will may say, I want my IRA to go to Sharon, you know. Well, if Sharon's not the designated beneficiary, it's not going to Sharon. So make sure that they control that, okay? So your will can say whatever you want, but those beneficiary designations are golden. That's what is going to happen. So just understand that. That's extremely important. So those are the, you know, after death documents, you know, let's say the distribution part. Now, the while we are still alive documents are really what we're here to mostly talk about today. And that's going to include a power of attorney, which most of you have probably have already, you know, heard of. That's going to be for your financial and like personal property, any type of transaction that you'll need to take place on behalf of yourself. You're going to designate an agent to do that for you. Hopefully it is someone that you trust, because the power of attorney is arguably the most important document that you will ever sign. So let's make sure that person is going to be a good steward of the money if they need to be, and that they're going to be trustworthy. Now, they are going to have a fiduciary duty to you, but it needs to be the right person in charge of, you know, what happens, because that is a lot of power that you're giving them. And one thing I want to stress about the power of attorney, because you can't, you know, I see a lot of them come through the office and they're like, you know, people will come in and they'll say, well, the bank didn't accept my power of attorney, or, you know, it doesn't, I can't do this or I can't do that, and why not? You really need to make sure that it has everything that you need in it. Now, when we're talking about when you're looking at long-term care and things that are going to be happening maybe later in your life, that is very specific language that needs to be in that power of attorney. For instance, if we are looking at long-term care planning and possibly Medicaid planning, because with long-term care, there's 3 ways to pay for it. And I know the guys here, we're all going to talk about that a little bit. That is, you pay out of pocket, you have a long-term care insurance plan, or you qualify for Medicaid. And Medicaid is needs-based. So we have to get pretty creative with what we do with assets. You do not have to spend all of your money down like people will tell you. Florida has a lot of tools that we can use to employ that money elsewhere, and so you can actually qualify for Medicaid if you need long-term care, because it's a huge expense. Most of my clients are paying like about $13,000 a month. So that's for skilled nursing care, okay? So in order to do that, let's say I have a client that comes in, they need to start planning for Medicaid for their mother. Maybe she has, you know, $80,000 in the bank. Well, she has Alzheimer's, so that $80,000, guess how long that's gonna last? Not very long. And then what happens? She has nothing. Kids have nothing, nobody has anything. So she can either go ahead and spend all of that money down and have nothing, or we can try to save the money to help her, you know, support her through this time and get her qualified for Medicaid. Well, if that power of attorney doesn't have that language in it that we need, we can't do anything. So it's extremely important to make sure you have everything that you need in your power of attorney to make sure that you can properly plan and prepare for things that may happen to either for yourself or for an elderly loved one that you may be planning for their future healthcare needs. And then, of course, we're also going to have our living will, which is going to talk about how we want to be treated medically, you know, in the event that we are in a persistent, if we're incapacitated and we, you know, are in a persistent vegetative state or have an end stage condition, then, you know, whether or not you want to be kept on life support is going to be, you know, something that you'll have to decide. And I encourage people to make that decision ahead of time so that your family doesn't have to make that decision for you, because that's a heavy burden for someone. You know, it's not a fun decision to make for people, especially when you really don't know what their wishes are. So it's a great way to document how you feel about it ahead of time. Now, I also like to prepare another advance directive, and that is an advance directive in the event of dementia, because dementia is a different type of disease, really. When you have a dementing disease, things stop working. You're not able to eat. You're not able to swallow. Dementia is on the rise, unfortunately, in this country. So I really think it's important to prepare for that eventuality. I think for everyone, really, because there's a different, there are different medical issues in the event of dementia, mainly involving nutrition and hydration. So we address that specifically in that advanced directive in the event of dementia, whether or not you want to have hydration and nutrition, which is going to involve the feeding tube. Has anyone ever had any experience with someone that had a feeding tube? I have a client, it's not pretty. I have had a client who the facility put a feeding tube in, and he was prolonged for several months, and the family was just outraged. They couldn't, do anything.
Once you do it, you can't take it
You
out.
can't.
They won't tell you that.
Right. So that's why it's really
Say
important.
you're gonna die if you don't do it. That's
Yeah.
what they tell you.
Right. And that then prolongs that. If you have, we're talking about dementia, okay? You're not going to recover from that. It's not going to automatically, So whether or not you want to have a feeding tube, I would suggest you really make that decision ahead of time. I think the key for all of us here, and for me especially, is don't wait. Let's make these decisions now. Let's document everything while you still can, because afterwards you're not going to have all of that control over yourself, and which brings me to the next document, which is going to be the designation of healthcare surrogate. And that is it's like your medical power of attorney. That's just what we call it in Florida. And that's going to be the person that you trust most to make your healthcare decisions for you. So make sure that they understand exactly what you need. Talk to them about these progressive diseases so that they know what it is that you want the end of life care to look like, and that progression as well. So everybody can be on the same page. I think I just have one more, and it's a HIPAA release, but
Go ahead.
that's it. I always go too long, so I'm getting the curtains closing. So anyway, I look forward to any of your questions and talking to you afterwards. But now I'm going to turn it over to Chris, who is going to probably be a lot more interesting than me.
I don't know about that.
Do you want this mic or no? I think I can take
Oh,
it.
no, I can,
You can project.
Y'all hear
I'll
me?
turn it off.
I can boom it out. Hi, I'm Chris Adams. I'm with a place at home in Jacksonville, and I do in-home care. I like to call it in-home help, because everybody thinks that care, we gotta hover over you, we gotta take care of you. But I always tell the folks I talk to, it's little things like, especially to the ladies, as you get much older, you may shrink a little, you put your dry clothes in the washer, and then how do you get them out of the washer? Because you can't reach, or they're too heavy. So y'all have the bright idea to get on a stool. And you get on a stool, you try to get the wash out, and then you fall. You break a hip, and that starts the cycle of going to the hospital, the ER, the hospital, the rehab center, and so forth. So we're here to prevent that, and that's why I like to call it help versus care. So you all see commercials every day, and everybody's happy, everybody's taken care of. I'm assuming you're a caregiver. Oops. And, they're in the park having a good time, and this actually happens. I'm not making fun of it, it actually happens. But this is where most of you all are, right? Independent, running around, coming to library speeches. And we can help you from there until you need care. Because we offer all these services, and you get these in your home. You get the personal care, which is the bathing, the toileting, the help feeding. And that's towards our end stage of what we need to do. Medication management. I get a call from a lot of adult children that, mom, dad has 47 different medications. I can't put it in a box every week because I have my own family, whatever. We can do that. That's a very short stay and just make sure and manage your meds. Our first mission is to get you off 47 meds. So we go talk to your doctors. Base case scenario I have is I walked in on my dad, he had 57 bottles of medication because he had a VA doc, an oncologist, a primary care, a hematologist, and whatever ophthalmologist he had. I called the primary care guy, we got it down to 7. So y'all are taking some useless medication, you have multiple doctors. Companionship, we can just offer companionship, which is easy, like I have one gentleman who we meet with every Friday because he wants to go to Dairy Queen. Meaningful activity, we love that one. Caregivers eating wings. We help with meal prep and nutritional support, so we make sure people get their food and hydration they need. And meal prep could be from putting in that lean cuisine to actually I have caregivers who actually are pretty good cooks and make a decent meal for people. Light housekeeping, I talked about the laundry. Swiffer the floor, dust, vacuuming, have a pet, see if the pet's taken care of right. We don't like litter boxes, but we take care of litter boxes as well. Transportation assistance, we take care of a lot of VAs where we drive them to Gainesville, because that's where their VA doc is, or Middleburg, or St. Augustine. We also do respite care, where respite can give the caregiver a break or the family a break to do that. And then we have specialized care programs where, depending on your diagnosis and your disease process, we do dementia care, we've repeated ourselves there, Alzheimer's care, Parkinson, stroke recovery, and just we get our caregivers quality just to be a great caregiver themselves. And this is where that care comes in too. And as Emily said before, how do you pay for home care? We don't do Medicare because we're not skilled, but we can help you stay out of the hospital, stay out of the rehab centers, even try to keep you out of your doc's office. So it comes out of pocket, long-term care insurance, Medicaid, and this is the last one, Veterans Administration. How many here are a vet or a spouse of a vet? Have you signed up with a VA doctor? Because I'll pay for aids and attendance and other benefits we'll pay for VA. And folks, if you're a veteran and you're not in the VA system, I encourage you to go. Because Congress has given vets a lot of money. Whether you're in World War II, Korea, especially if you're in Vietnam, there's plenty of money out there to take care of you. It's not income regulated. There's a lot, as I say, there's a lot of millionaires who are getting VA benefits. And especially Vietnam vets are getting a lot of benefits for Agent Orange, stress syndrome, whatever else. So, and also once you're in their system, it's easier to get that benefit than trying to get your private primary care physician to do that. So you want to stay in your home, huh? Well, is your home ready for you to age in place? Is your family ready or willing to have you move in with them? Or they move in with you? Are the services I need available to me in my home? When's the last time did you have a house call from your primary care physician? Well, there's services out there that can take care of that for you if you stay here. And then the ultimate question, do I really want to stay in my home? Some people may not want to do that. Personally, I'm staying in my home. And then make a plan. Emily talked about plans, Michael's gonna talk about a plan, I'm sure you're gonna talk about a plan. You gotta make a plan. I've been seeing more and more folks in their mid and early 70s making a plan where they don't even need services.
Oh, there's a door stop.
And I talked to, let's say, 5 in the last 2 weeks. They called me because the spouse is getting surgery in a few weeks. and they're gonna need some help, but they're already planning for when they're, 75, 80, 85 to 90. Transportation, how long are you gonna be able to drive? Not that's how you think you can drive. When the law enforcement may tell you you can't drive. I was lucky both my parents gave up their license pretty early. They both had macular degeneration and they gave up their license. Another consideration, how is my current vehicle gonna last? I currently drive 10-year-old vehicles. Anybody go car shopping lately? It's amazingly expensive. I happen to like F-150s, and a brand new one is 75 grand or more. A used one's about 40. So, will my family be available to drive me? How many have adult children that work full-time? Or taking little Billy over to baseball, or Susie to dance class? Or you gotta take a day off from work? Do you know what transportation services are available? I mean, anybody use an Uber lately? That's expensive. Public transportation, anybody take JT, this is St. Johns County. Well, Duval has JTA, Clay County where I live, they have their transportation, but there's no guarantee they'll pick you up in 8 hours after you leave your home. And then senior social services transportation. So there's services out there, but they may not be that cost effective or fit into your schedule.
Unknown caller.
Is that mine or? Oh, that's okay. And then, like I said before, is my house ready? Is your home accessible in case you need a walker, electric scooter, God forbid a wheelchair? Do I need a ramp, flat thresholds at doors? Go home and look at your doors. There's a little aluminum piece that can stop a wheel, walker wheel, wheelchair wheel. Is my bathroom accessible if my needs change? Please don't call up a contractor and say, oh, I need grab bars. Because he's gonna look in his ADA book and he's gonna put them 36 inches high and he's gonna put some around your toilet, and if you happen to be under 4 foot, you're gonna be like this trying to get out the butt. So you can get occupational therapy to come in your home. It's paid for by Medicare, and they can put the grab bars where you need them, not where the ADA says they are. And I also work with contractors who are very willing to make it customized to you, and they're very inexpensive. A no-step shower, shower chairs, a walk-in tub, an ADA toilet. All those can be adjusted in your house. Do I have any fall hazards in my home? Biggest problem for falls is throw rugs. How many of y'all have that beautiful rug that your great-grandma gave you and you're gonna fall over? Because if you have carpet, it's going to be. Pets do the same thing. My pet leaves their bones around all the time. Make a plan. Will I have the services I need that can come to my home? Primary care physician, medical services such as dental, lab, medications, and x-ray. You can get those in your home. I talk my vet into doing vet visits, because typically seniors have senior dogs, cats, and pets, and they can't love them. Do I have trusted home services for my home? A trusted housekeeper, handyman, other services that you may need, plumber. Final thoughts. Do I want to stay in my home as I age? Biggest question, we gotta talk about that. How will I have services like transportation, medical, and general services? Is my home ready? Will I need assistance to stay in my home? And that's where people like me come in, that wonderful caregiver there comes in. And where can I find the resources to assist me in my home? I'm one of them. I'm a family-owned and operated business. You call me, I can give you as many resources without any obligation. I'm not a used car salesman. I'm not here to run up hours. I don't have quotas. And that's me, and I just got cut off. All right, thank you so much for your attention. I hope this helps you. And
So I get to build off of what Chris just presented, and you're gonna see a running theme with me, which is, it is a lot easier to help you if you have a plan about what you kind of want and know. So my name's Mike Saffy. I'm the owner of a company called SilverLink. We do a lot of different things. Mostly what we do is help older adults and their families navigate long-term care options. So I'll give you a couple examples of clients that we've helped, just the past week or so. We've had several people who come to us from the hospital. They've maybe been trying to make it on their own at home. Now they can't anymore. Unfortunately, something happens, and now they're in a crisis. So if you've been hospitalized anytime recently, you know how much of a pain that can be. Sometimes you go in, you might stay for 3 days if you're lucky. It might be the 3 right days that Medicare will cover. And then what comes next? You get a social worker knocking on your door, and they're telling you, oh, sorry, you can't stay here anymore. You got to get out of the hospital. Oh, what do you do? Okay, well, you can go to rehab. Okay, well, Medicare only covers that for so long, but you're not fully recovered. Then what do you do? Most of the time, that's where we jump in and will help families navigate through a crisis. We much more prefer to have families come to us preventatively, which is why I love doing education events like this. So my company is what's called a placement company. So we're a little bit of a mix between social workers and real estate agents. When you can't stay at home anymore, whether that's for financial reasons, maybe it's just costing too much to have care in your home, or if it's a legitimate medical need, or maybe you just want to downsize and move into a community that's going to do the housekeeping, and you're going to have all your meals covered, and you're going to have all your utilities paid for, so there's not 20 bills to operate your home. All of those things are what we help with. So we help families figure out when the right time to move into independent living, assisted living, and memory care communities are. And we also help you figure out how to pay for it, which is what I focus on. My background's in managing assisted living, so I got to do that in the Beaches area for 6 years before I started this company in 2017. And Chris will tell you, in-home care is awesome, but there are kind of limits to it, and it also depends on your budget. You've heard that term private pay 3 or 4 times now. Well, how much are you going to pay? If you're managing at home, it depends on how much in-home care you're going to get. How do you charge, Chris? By the hour?
By the hour.
What's the average rate per hour?
Our average rate per hour in this market is about $35.
$35 an hour, 4 hours minimum?
Yeah, usually to get the most out of us, it's 15 to 20 hours a week.
Yep. So on the low end, if you've got a caregiver coming in 4 hours a couple of times a week, probably looking at about a $3,000 outlay a month. Plus, if you have a mortgage, if you have utilities, property taxes, maintenance on your home, God forbid you buy groceries. Those seem to get more expensive every hour. On top of that, you might have the car payment. You might have all these other payments to manage your household. All of those things add up. And at a certain point, you reach what we call the financial tipping point, where it may be better for you to consider moving to a community and getting all of those needs met under one price within a monthly budget. The average cost for independent living is not as much as you would think. It sounds expensive at first. Maybe a 1-bedroom apartment usually is about $3,500 a month. I didn't see anybody's eyes get big, that's good. So with independent living, you're gonna get all of your meals covered, all of your maintenance for the apartment or the villa. Some of our independent living communities have true houses. You're gonna get your weekly housekeeping done, and you're gonna have access to basically like a country club full of activities. So that's independent living. That's basically all of your living expenses, room and board kind of covered under one cost. The next step up would be assisted living. That's where you start getting physical care. So in the assisted livings, that's actually licensed by the state of Florida. It's governed under the Agency for Healthcare Administration, so there's some rules and regulations with it. But on average, for a one-bedroom apartment for an individual, you're probably looking at about $5,000 a month in this area, in St. Johns County and the beaches. That also includes your care. So that might be all of the things that you would need help with physically at home: medication management, bathing, dressing, grooming, toileting, any type of nursing need except really, really skilled stuff. So assisted livings can handle up to a 2-person transfer, which basically, the way I describe that, if I can get 2 NFL Jaguar players to come and pick me up and help me into a wheelchair from the bed, I can still stay in assisted living. I can stay in the community as long as I'm able to do that. Most of our clients will spend the rest of their life in assisted living once they get there. There's really not too much of a need to move unless you don't do some of those advanced directives plannings that Emily talked about earlier. Things like feeding tubes, tracheotomies, you know, all the things that most people don't want to have happen to them. So in assisted living, it's basically the exact same. You've got a nice apartment. Some of them have full kitchens. Some of them have large floor spaces. You know, one of our communities we work with has 2,500 square foot assisted living apartments. You know, they're like penthouses. And again, you know, $6,000 or $7,000 a month. Now, out of that might be some benefits. So we saw a couple of veterans. There's the same benefits that you can use to pay for in-home care for the most part, like aid and attendance, for example, for through the VA. On average, that's going to cover a veteran about $2,000 a month to pay for care. So if you're at $6,000, now you're at $4,000. Then hopefully you have Social Security and maybe a little pension. We subtract that out. Now we've got what we call your burn rate. That's how much your savings and your assets are going to go every month. So we help you figure out of how much you're spending, how long will your savings last? And everybody is different. Some people own their homes outright. Some people bought, you know, in Ponte Vedra in, you know, the 70s. My granddad could have had that opportunity. I wish he did it. He did not. You know, it just depends on how much equity you have in your home, how much savings you have, things like that. So we sit down and do a one-on-one consultation with you to go over all those details and then help you figure out which community is right for you based on those wants and needs. The last type of community that we work with is memory care. They're still usually under the assisted living license, but that's when somebody with dementia, we're worried about them just wandering off. We call them an elopement risk. So it doesn't mean that, you know, your loved one's going to run off and get married in Vegas. What it really means is that we're worried about them getting confused, wandering out all these different exit doors, not knowing where they're at, and then wandering onto A1A into traffic. It's basically the exact same as assisted living with a little bit different programming that's geared towards dementia, different activities, different, you know, trained staff, things like that. And there's secure doors. So if you want to go outside, you're going to be escorted with some help. If you as a family member want to come and pick up your loved one, you can do that. You just sign them out, you take them out for the day, you can take them out as long as you want, so you're not locked in. A lot of people think that it's like prison, you know? It's not at all. You can come and go as you please with supervision and memory care. And assisted living, you come and go as you want. You can go out to the beach bars and come back at midnight, you know? It's your home. The staff just happen to work in it and care for you in it. Now, we heard some big numbers earlier, like 10,000 plus a month. Now that is for skilled nursing. Private pay skilled nursing is kind of the end of the line. So if for whatever reason your needs can't be met in an assisted living license, that's the alternative. And skilled nursing in the Jacksonville, Northeast Florida area has gotten really, really difficult. Availability is tough to find. It's hard to find a community or a skilled nursing facility that's going to take Medicaid benefits pending, which means they want you to pay out of pocket until somebody like Emily comes along and helps you with your assets, gets you approved for Medicaid, things like that. And even then, at the end of it, they can still take all of your monthly income even after Medicaid. So that's why we try to help people proactively plan ahead for when they're ready to move and when the time is right, so you don't overspend, you don't go into the wrong type of facility and get the wrong type of care. You know, if you just need help, you know, maybe getting out of bed or maybe injectable medications, things like that, those types of needs can be met in assisted living just fine. Why spend double to go to a skilled nursing and be in a hospital room? So that's what I do in a nutshell. And I covered the financial tipping point. I need my little cheat sheet here. I'm gonna steal Charlene's cheat sheet. I had one more thing. Oh yeah, third parties. So in assisted living, the other benefit to that, kind of like Chris mentioned, there's visiting physicians. So in assisted living, you're gonna get all of these services covered under Medicare as third parties. So we have things like physical therapy that is in-house, that's billed through your Medicare insurance. You also have visiting primary care doctors that will come in, cardiology. We have mobile x-rays, lab work, so you don't have to go out to Quest, you know, and get your finger pricked. They'll do it in the comfort of your apartment. All of these other services that are available. Hospice is a big one as well. When the time is right, Charlene's gonna tell you about, you know, what hospice services look like. All of those can be met in the community so that you can live there ideally the rest of your life and age in place once you get to that point. So this is the part where I always open it up for questions because most people kind of are afraid of assisted living. It's like a nasty term. And until you go and see one, which, you know, we tour with you on those communities, it's hard to describe. It's scary until you actually see it. So, you know, consider that. If you have any questions, I'm always here to help. And me and my team are happy to be a part of this and keep everyone educated. All right.
Thank you, Michael. And if assisted living is a scary word, hospice really scares people. And I'm so happy to be here because I don't think it should be something that frightens people. There are so many myths about hospice care, and I can tell you, I was a recipient of hospice care through the care of my father, who had end-stage ALS and was in the community hospice program for almost 8 months. Could not have done it without them. And my mom was up in North Carolina in an area with no hospice. It was dramatically different. So I'm happy to be here to share information with you. And not everybody will need hospice, but most everybody will know someone that does. And it's so important to understand what's really available. So what is hospice care? It's not a place. A lot of people think it's a place. You hear people say they went to hospice, but it's really a philosophy of care. It focuses on comfort care, on dignity for the patients. It's a very holistic type of care because with hospice, we focus on not only your physical needs, but also psychosocial needs, emotional needs, and spiritual needs. And it makes such a difference to have all of that addressed for individuals that are at end of life. So at hospice, we believe that individuals are entitled to live their lives with as much quality as possible during the time that they have left. We neither hasten death nor artificially prolong it. We're there to make it as natural as possible, allowing the patient to spend time with the family and the family to spend time with the patient and the loved ones in as comfortable of a way as possible. So who's appropriate for this type of care? It is any individual with any sort of end-stage illness that has a prognosis of about 6 months or less. And this is a Medicare guideline. Now, don't let the 6 months frighten you. We have patients that have been in our program for a few years. Jimmy Carter, he's been in hospice for 1.5 years now. But there's a prognosis because hospice is not set up to care for people with chronic illness for years, 4 years, 5 years. It really is an end-of-life sort of program. And another myth that people have is, this is it when I go into hospice. Well, hospice is a choice. It's a patient-family choice. Once you are admitted into a program, if you try it out for a few weeks and you don't like it, you can discharge us. And you can come back sometime later if you like. Sometimes we have people with cancer that there are some aggressive treatments available, but they're exhausted, they've been in a lot of pain, and they've decided that they really don't want to get those treatments. So they're shifting from curative care to comfort care, and sometime after a couple of months, and their pain and symptoms manage, and they become more comfortable, they tell us, hey, I'm going to discharge and I'm going to try that other treatment that my oncologist suggested. And they can come back in the future. Sometimes we see them again in the future and sometimes not. But I just want to share that with you because I think that 6 months really concerns people beyond where it really should. So once you are admitted or accepted into a hospice program, what do the services look like? Well, number one, the hospice benefit covers your medication related to your admitting diagnosis. It covers any supplies that are needed and medical equipment that's needed in terms of shower chairs, bedside commodes, hospital beds, anything we can provide that will help to make the path easier for the patient and for the family and the caregiver supporting them. A team is assigned, an interdisciplinary team is assigned to each patient and family. And later you'll look in the bag I gave you, there's a circle. And that circle, that's members of your team, but right in the center is the patient, family, and caregiver. You are the captain of the team. We have medical directors and nurses that are experts in pain and symptom management, and they come out and they monitor, the nurses come out and monitor the medications, make sure the patient's comfortable. And I can tell you from my experience, our nurse would come out and take care of Dad, make sure he was comfortable, talk with him a while, and she never left without coming up to me and saying, Charlene, your dad's doing pretty well. How are you? Well, sometimes that opened up big conversations and I needed her support myself, but it was just so meaningful to get that sort of support. A social worker is also assigned to help with counseling, education on what you might expect along the way, connecting you to services in the community that you or the family might benefit from that you're not aware of, and a lot of guidance and support. If needed, we also have certified nursing assistants, and they are unsung heroes. They will come out and do bathing and grooming, and I can tell you when we got my dad, who was 6'3", into the hospice program, the first, I had been bathing him, I had been shaving him. It was a lot of work, but I thought I did a really good job. When I saw our CNA shave him and bathe him, she put me to shame. And my dad let me know that. So they are really wonderful with, really giving dignity to the patient and providing good care, and it really can make a difference for the family. We have non-denominational chaplains if you would desire for them to come out, and they meet the patient and family at whatever level that they are at. And sometimes people have a lot of spiritual questions at that time of life. We have volunteers. Volunteers are the heart of hospice, and they are specially trained. They are wonderful listeners. They are fully screened, just as the clinical staff is. And the volunteers come out and they can sit and spend time with the patient. They can give the caregiver a break to maybe go to church service or shopping with friends, or maybe go to her own physician, his or her own physician. So they can make a big difference, and they're great companions for the patients. I started as a volunteer before 2000, and when I saw the difference it made, that's when I sought employment with community hospice because I knew it really made a difference in people's lives. There are also some additional team members. Community hospice, we're a nonprofit, so all of our monies, we don't have stockholders, we don't have to take care of that. So all of our funds go back to the community, and we have a depth of resources, and we have some different individuals that come out and provide care that you don't always see. We have music therapists that can come out. We have pet therapists, and they are awesome, and their pets are specially trained. We also have a child life specialist. So if there's a child in the home that is having trouble understanding what's going on with the mom, what's going on with grandpa, they can come out and work with them at their level. They might use play therapy, but they work with them at their level, and that can make such a difference. So how do you pay for this care? We talked a lot about cost, and nothing is going down in price, but hospice is paid for by Medicare, Medicaid, most insurance policies. TRICARE has a hospice benefit for the military, and the beauty of nonprofits is we care for people regardless of ability to pay, because we do $3 or $4 million of unfunded care every year here in our territory in Northeast Florida. So you never have to worry if you feel someone needs it and you want to suggest it to them. You don't have to worry about whether or not they can afford it, which is really, really helpful. So we talked about the fact that it's not a place and you have your own team. So where do we provide that care? We provide that in the patient's home, wherever that might be. It may be a private residence. We've cared for people on sailboats. We also provide care, as Michael was talking about, all the different levels of care. We provide care to individuals in assisted living facilities, in nursing homes, in memory support units, which are coming more and more prevalent. And that's, a lot of people ask, why do you need it? We also help individuals in nursing homes. We're considered experts in end-of-life care and pain and symptom management. We help support the staff, but we're there for the patient, and we provide an extra set of eyes, additional care, and report to the family. So it really makes a difference to be able to get that additional care. We do have inpatient units. Some of you may be familiar with the Hadlow Center for Caring on Sunbeam Road, McGraw Center at Mayo. We have the Bailey Center at Flagler. These are small inpatient units that are just for short-term care. If we have someone that maybe needs to be stabilized before they can go home and be on care, or if they have some symptoms that are best managed inpatient, but they're short-term care, and only about 5% of our patients need that sort of care. So, and we have someone in all of the hospitals as well. So what are the benefits, kind of wrapping it up? We're caring for the patient at all of those levels, spiritual, emotional, psychosocial, and physical. We're supporting the family and the caregivers. Once you're on the program, we're available 24/7. With my dad, sometimes we were calling at 2 in the morning, and sometimes the nurse would come out, and sometimes they were able to talk us through what we could do to make Dad more comfortable. We also provide, hospice benefit includes respite care, where the patient can be moved into one of the inpatient units if there's availability, or into a nursing home we partner with to provide care for up to 5 days if the caregiver needs to go to a wedding, needs a mental health break, has to take care of some of their own health needs, and we follow them with that care. So though they may be, if it's in a nursing home, we continue to follow them with that plan of care and report to the family wherever they might be for that short time. So that can be incredibly helpful. So with that, anyone can refer to hospice. We get a lot of referrals from physicians, hospitals, nursing homes, assisted livings, but anyone can refer. Call in and make the referral, and then we can determine whether or not a patient is appropriate. And I thank you for your time. I hope we'll have lots of questions at the end. But I'm glad to be here because it is more and more people, especially since COVID, are waiting till they're in crisis. And so much more can be done to support the caregiver, the patient, and the family. And don't forget, we also provide up to 13 months of bereavement care to the family after the patient passes. So if you remember anything, remember community hospice. Think about life and living as fully as possible for the time you have left. Thank you.
Dr. Brittany.
Thank you guys so much for coming today. Did everyone learn something new? Yeah. Another quick applause for our speakers. I think they're so brave.